Welcome everyone to Black Cervix Chat. We're so happy to have you here on a Saturday. As everyone is joining, please utilize the chat. While you can see us, we cannot see you. But we are sure wherever you are, we're just happy to have your beautiful selves here with us to talk about this very important topic. In the chat, you can let us know where you're listening in from, where you're watching, if you're a survivor, if you're a patient. What are you anticipating to learn today? Anything. We are going to get started in just a few. We have a dynamic panel today. I'm always so appreciative of people giving time, even on a weekend, to talk about something that's so very important. I want to thank the Survivor team for putting together this chat. It's very important. We know that statistically, cervical cancer is not declining as it should, and we want to make sure that those who fall in health disparity gaps, that we close those gaps. So we're going to kick this off. Next slide. Hello. If I haven't had the pleasure of meeting you yet, my name is Tamika Felder. I'm a long-term cervical cancer survivor, and I'm the founder and chief visionary of Cervivor, Inc. Next slide. I look at this picture and it literally puts a lump in my chest. I'm hamming it up here, but I was not feeling my best. This is when I was working during treatment for cervical cancer when I was diagnosed at 25. And I think about that time and I cannot believe that one, I've survived, but I've thrived, but I've also been so blessed to start this organization and do such meaningful work so that others can not only be diagnosed at early stages, that we can comfort them, but we can also prevent it so that future generations never have to deal with this or any other HPV-related cancer. Next slide. 25 years old. Someone dear to me just turned 25, and my first thought was 25, you're a quarter century old. What an amazing feat. But then I remembered at 25, I was diagnosed with cervical cancer. Next slide. I was living my life as a television producer. I'd moved from South Carolina to the Washington, D.C. area, and I was just checking off every single thing on my list. And then cervical cancer came in, and those three letters with that long word that I didn't have any knowledge of, human papillomavirus. And it took so much from me. I had a radical hysterectomy followed by chemotherapy, radiation therapy, the loss of my fertility, and secondary post-cancer issues that I still deal with today. And quite frankly, they are problematic, but the truth is that I'm still here and I'm still grateful to be here. Every single journey is different. People will do what they need to do to survive. And for me, it really was, I didn't want to die. I had so much more living to do. Next slide. In 2000, cervical cancer wasn't being talked about. Breast cancer, lung cancer, skin cancer, colon cancer, many cancers, prostate cancer that had touched my family. But when I was diagnosed, cervical cancer wasn't being talked about. And the truth of the matter is, in 2001, we didn't have social media. We didn't have these type of platforms to come together and educate. And I turned to AOL chat groups. I turned to my local library. I went to my local bookstore. And honestly, the things that I found didn't make me feel good. They didn't make me happy. And they were faceless, nameless people. So then I was like, I I should be ashamed of this. This isn't something how did I do this to myself? And that made me feel really bad. Next slide. And as an educated, college educated woman, I'm going to be honest, I didn't know exactly where my cervix was. I knew the area, but I didn't know what its function was. I didn't know why it was needed. I didn't know how you could survive without it. I just didn't know these things. And that made me feel bad. And so I literally consumed so much information about what I affectionately called coochie cancer so that one, I could know one, what was happening to me and how could I stop it from other people. And the irony is, I think I became a patient advocate then, even though I didn't know what a patient advocate was. Next slide. Um, this is preventable. We always hear that we want to win the war on cancer. This is it. Unlike so many other cancers, cervical cancer has routine screening and you can have early vaccination that can prevent you from having these types of cancers. And why wouldn't we want to do something about that? We should, right? And what I learned early on is no one was talking about it because the stigma was so high. Next slide. My why became Survivor. It became what I wish I had when I was going through this. And when I hear someone now say, I wish I would have found you sooner, it makes me work even harder so that people know, one, we exist, and two, that they are not alone, and three, we can be we can be a part of the movement that eliminates cervical cancer. And I want you to know that it's an attainable goal, but we all have work to do. I want to thank everyone who's brave and sharing their stories because when you talk about this type of cancer, you are being vulnerable. And I thank you for that. Next slide. Connecting the dots. We know the cause. We have the tools to detect the cause. We have the tools to prevent the cause. These numbers, we can change them not only in the US, but globally. And we've connected the dots. Now we have to do the work. Next slide. Over the years, this organization has grown and it's evolved. But the one thing that is still true, that there are people who die from this disease that no longer have to. We are a part of the generation that's going to change that. Next slide. Our mission is the same: end cervical cancer. Next slide. I am so proud of my Chief Diversity, Equity, and Inclusion Officer, Kimberly Williams. She is a survivor. She is a thriver, and she is on a mission to make sure that communities of color do not fall through these cracks. And so without further ado, Kimberly Williams, I hand it over to you.
Thank you, Tamika. I appreciate you. Um, I'm so excited, and I echo what Tamika has already stated as far as you taking time out of your Saturday to be here. I'm just going to introduce myself a little bit, explain why Black a Cervix Chat, and hand it over to some of our amazing panelists for today. Next slide. So how it started for me, as Tamika stated, I am a cervical cancer survivor, but before cancer, I was and still am a mom of two amazing kiddos. I was a wife at the time and a director of an organization. And so I felt like at the age of 42, I was finally finding my way in my life and how I was going to like check off the boxes that I didn't get to check off when I was in my 20s and 30s. At the age of 42, I was diagnosed with 1B2 cervical cancer. Of course, I was crushed and I felt like it was a death sentence. However, my physician said that, hey, everything is going to be fine, no worries. And they found some cancer outside of my cervix. And after a year of battling with my insurance, um, I found out that I had a recurrence. And so the cancer had moved to the other side of my body. And I had to have aggressive radiation and chemo treatment. So I dropped my kids off in 2019 at their first day of school. And then I went to my first day of chemo and radiation treatment. In October of 2019, I rang the bell twice, signifying that I was done with chemo and radiation treatment. In December of 2019, I received my first no evidence of disease. And then I felt a little lost, like, well, what now? What do I do? And I think as a cancer patient, your goal is to get through the treatment. But after that, then what? Next slide. Then I found my voice through Survivor. I tell my story. I'm sure lots of people have heard my story, and that's okay because I want you to not go through what I've gone through. Next slide. And this is again just from me telling my story, and I won't stop. And that's one of the things that I continue to do. Why? Because this is a preventable disease. Next slide. Black women in cervical cancer. Black women are more likely to die from cervical cancer than other races. And so it starts with us by sharing information. Next slide. And this is our commitment. And one thing that I can say, Survivor stands on business. They mean that we are going to be committed to health equity and embracing diversity, equity, and inclusion. Next slide. So Black Cervix Chat, we're cultivating awareness, education, and empowerment within the Black community. We want Black communities to prioritize women's health, bridge gaps in healthcare access, provide a supportive space for discussions related to cervical health, screening, and general well-being, and make a lasting impact on cervical cancer disparities. Next slide. So without further ado, I'm bringing up Dr. Evelyn, and she is a gynecology oncologist. Dr. Evelyn, the floor is yours.
Good morning / good afternoon. Thank you so much. I'd like to thank Survivor for inviting me here, and Kimberly, thank you so much for sharing your story with us. So as was mentioned, my name is Evelyn Cantillo. I am a gynecologic oncologist at Weill Cornell Medicine in New York City. Next slide. So this is a very quick cervical cancer 101. It's really kind of difficult to do in 10 minutes, but I will do my best. Next slide. So I think Tamika highlighted a lot of this. I can do this a little quicker, but really basic. What is the cervix? I feel like a lot of women really have an idea, but don't really exactly know what things are. So I always start with really basic explanations and really bad pictures that I draw myself, but I show this picture of the uterus and the cervix, which is for us kind of treated separately as physicians, but for women, it's just like this one structure, the uterus and the cervix. And if you see in this picture, the cervix is the bottom part of the uterus. And when people are diagnosed with cervical cancer, it tends to occur at a place where two different cell types meet. So if you look at this picture of the cervix, there's a canal. I like to say it's a tunnel that goes from the outside that we as doctors can see when we do a pap smear into the inside of the uterus. That little canal, tunnel or canal, is called the endocervical canal. And that has cells that are typically glandular cells, which for us is a distinction that we make. But for you, you should know that there's like this part on the inside that when we are doing a pap smear, your cervix kind of looks like a donut. And there's a hole in the middle of the donut, and that hole takes us into that canal that then leads into the uterus. Cervical cancer tends to arise from where that canal starts kind of exiting out to the kind of donut, the more formed donut part, which has a whole different type of cell on it. Next slide. So why does this matter? I mean, we should care about all cancers, but cervical cancer in particular is the second most common cause of cancer-related death among women worldwide. Uh, Over 600,000 cases and over 340,000 deaths were reported in 2020. In the United States, it actually ranks 12th. There are about over 14,000 estimated new cases and over 4,000 deaths in the US, and that was in 2020. I think it always hovers around 4,000 deaths per year, which for me, I think is still too many. Next slide. Um, this is important to highlight that this is a cancer unique to young women. It's most frequently diagnosed in women between the ages of 35 and 44. And we know that the time it takes typically for one to get from abnormal pap smears to a cervical cancer diagnosis is in the range of years. And so we have a lot of time to really prevent cervical cancer. And it really is the easiest gynecologic cancer to prevent through screening and early vaccination. Next slide. So what are the symptoms of cervical cancer? There's a picture here. This is a cervical cancer that is now a pretty large size cervical cancer that is something that can be easily seen on an exam when we as physicians are doing exams. The symptoms of cervical cancer: abnormal bleeding. So bleeding between periods, bleeding with intercourse, postmenopausal bleeding, having unusual vaginal discharge. Other symptoms can be like a leg pain, which is really sciatic-like, which is that kind of pain that happens in the back that extends down the back of one's leg, severe back pain, severe pelvic pain. The issue is that these symptoms can occur in lots of other things, but none of these symptoms are normal. So if any of these symptoms come up, you should follow up with someone so that they can check it out, because the important thing is ruling things in or out. And the truth is some women will have no symptoms. Next slide. So I'm going to go kind of big picture recommendations. These are screening recommendations that are agreed upon by the American College of Obstetrics and Gynecology, the US Preventive Task Force services, and the American Cancer Society. So in terms of just basic screening, it's not recommended to screen people that are under 21 years of age. Between the ages of 21 and 29, the recommendation is to do a pap smear every 3 years. From ages 30 to 65 years old, there are a couple of different options here. One is a pap smear every 3 years. Another is a high-risk HPV test every 5 years. And you could also do a co-test, which is a combination of the pap smear and the high-risk HPV test. This is basically if everything is negative. If your pap smear is negative, you come back in 3 years, or negative or normal. If your high-risk HPV test is negative, you come back in 5 years. And similarly, if the pap smear is normal and the high-risk HPV test is negative, you get a repeat pap smear and HPV test in 5 years. If someone's older than 65 years old, then the recommendation is no screening after adequate negative prior screening. And I will say what that is a little bit later. And lastly, if someone's had a hysterectomy with removal of the cervix, so, this is really important. It's possible to have a hysterectomy where the cervix is left behind. That's called a supracervical hysterectomy. In that case, you still need to have cervical cancer screening because there's a cervix that's still left. If the cervix was removed at the time of the hysterectomy, then no screening is recommended in patients that have no history of any high-grade precancerous lesions or any previous cancer diagnosis. And I'll kind of expand on that in a few slides. Next slide. So what causes cervical cancer? The central cause of almost all cervical cancer is a human papilloma virus. We know that human papilloma virus is responsible for like upwards of 90% of the cervical cancers that we see. HPV is transmitted through sexual contact. It is a really, really common virus. About 80% of people will get an HPV infection in their lifetime. And the thing is, most people actually clear the infection. They may never know that they even had HPV. Women kind of tend to find out because we do get pap smears with HPV testing, and the test may come back as positive, even if you had no idea that you had gotten HPV. HPV detected today could have been acquired years ago. It was really important. It is a virus, and so sometimes viruses will, we say, become dormant or go to sleep, and they can be reactivated. So it's possible to have acquired an infection many, many years ago. And so therefore getting a new diagnosis of HPV doesn't mean that it happened within like an immediate time to the time that you got the test. Most HPV infections are asymptomatic, meaning that they don't really cause any symptoms. And for everyone, especially for gynecologic oncologists, we care about high risk types of HPV. High risk HPVs are the ones that cause cervical cancer. High risk HPV 16 and 18 in particular are responsible for about 70% of cervical cancers. Next slide. So if I have HPV, does it mean I will get cancer? No, it does not. Can you think this is yeah. No. So in most cases, like I mentioned, HPV infection will go away, but in some people it will be persistent. There's another yeah. For 90% of women, HPV clears on its own in about 2 years. And only women with persistent HPV are at risk for developing cervical cancer. But that still gives us a lot of time to do a lot of interventions and a lot of monitoring to make sure that we don't get to a point where there is a cancer diagnosis. Next. And as I was saying, the time from an abnormal pap smear to a cervical cancer diagnosis is on average about 10 years. These are averages. Obviously, there are cases where things are actually a lot shorter or even a lot longer than this 10-year average. Next slide. So risk factors for cervical cancer. Increasing age, actually younger women. So women under the age of 25 in particular, even if they acquire an HPV infection, their chances of clearing the infection is a lot higher. So they have a greater chance of clearing the infection all on its own. HPV infection is obviously probably the biggest risk factor for the development of cervical cancer. Immunosuppression, so HIV diagnosis where your viral load is not under control. So you have a detectable viral load, prior organ transplantation, chronic steroids, anyone who's on immunosuppressant medication has a higher risk of not clearing the HPV virus, which we know is kind of the biggest cause of cervical cancer. Smoking has also been associated with a 2 or 3-fold risk of developing cervical cancer. And women who do not have pap tests, that is probably one of the biggest risks for cervical cancer as well. In addition, we have to, we talk about the United States as it's not as much of an issue. However, there are populations in which it's actually not true. Women in the United States that are at high risk for developing cervical cancer are those with poor access to healthcare, or maybe they have healthcare that they can access, but there's no way for them to get there because it doesn't align with their job schedule, or there's no way for them to physically get there. Women without health insurance and women who immigrated to the United States within the past 10 years are all at a higher risk. Next slide. So, yeah. So thank you. And just kind of touching on the cervical cancer disparities in the United States, we know that Black and Hispanic women are at higher risk for cervical cancer compared to their white counterparts. We also know that those that live in non-metropolitan areas, so think really rural areas, places where it might be 50 miles to the nearest physician, or 1 or 2 hours to get to a place where you can get some type of management and follow-up, well, that's already setting up an inequitable situation where people just can't. It's not that they don't want to, it's just that it might be really difficult, or even almost like something that they just can't do. Women with lower socioeconomic status, these things all start to kind of blend together. And then those who have never been screened, or those who haven't been screened in the past 5 years, also are at increased risk for cervical cancer. Next slide. So although about 80% of historically marginalized women have undergone pap smears within the last 3 years, we know that African American / Black women, Hispanic women are more likely to present at later stage of diagnosis. Black women are twice as likely to die compared to their white counterparts. I mean, we could do a whole lecture as to why that is happening. There's a lot of, I think, racism in healthcare that needs to be addressed, but there's also kind of the issues I was talking about, things being really far, not having health insurance, loss to follow-up after an abnormal pap smear is a big one. And worsening disparities are noted in older women who are ineligible for HPV vaccination or are underscreened. And, HPV vaccine, I'll talk about a little bit, is really, really effective. And we in this country in general have pretty much stayed at the same place in terms of the vaccine rates, and they could be better. Next slide. So kind of, when can I stop having a pap test? So the American Cancer Society says cervical cancer screening can stop at age 65 if 3 or more tests have been normal and no abnormal tests in the last 10 years. So that is the recommendation, which is why they say to stop at 65. However, the problem with that, can you just hit next, please? Black and Hispanic women are actually been found to have a peak incidence of cervical cancer in their 70s. So this is like another peak in addition to the one that happens earlier in age. Next. Many older women assume they can't get cervical cancer. In fact, more than 20% of new cervical cancer cases occur in those over 65. Next. So the questions for a lot of people is, do you know when your last pap smear test was? I think a lot of people think that when they go and get a pelvic exam, that's the same as having a pap smear. Pelvic exam is when the whoever the provider is puts that metal, the speculum, it's like that metal contraption, into the vagina to take a look at the cervix. A pelvic exam in and of itself is not a pap smear. The pap smear is actually taking the cells off the top of the cervix and sending them for testing. So it is really important to know that the pap smear is not the same as a pelvic exam. So sometimes even just asking, was a pap smear done today? Are you doing a pap smear? Why aren't you doing a pap smear? So that you're also aware of what's happening. Next. And then, for older women, there's a whole, the population in the United States is getting a lot older, a lot more active, and people are still sexually active. And we expect that sex is a part of life, and we should be talking about that. So I think it is expected that women in their 60s might have new sexual partners. And if that's the case, then I don't think we can really go by this stopping cervical cancer screening at the age of 65. Next. So how can we change rates? Next. So cervical cancer prevention, primary prevention, preventing cervical HPV infection. So, one option is complete abstinence. That might work for some people. I'll say for most people, that's not going to be the approach that wins. However, vaccination, HPV vaccine is highly, highly effective, especially prior to the onset of sexual activity. I think after COVID, everyone has like a mini PhD in vaccines. So we know that getting a vaccine before you get the actual condition is always going to be better. So for HPV vaccine, if that's given before before people become sexually active, that's going to be the most effective. The recommendation is to start the vaccine between the ages of 11 and 12 for both boys and girls. It could be as early as 9, but 11 and 12 is the recommendation. It provides protection against high-risk HPV 16 and 18. And in the United States, actually, it protects against 7 other high-risk HPV vaccines that account for about 90% of the cervical cancers. So we have a vaccine that can really prevent cervical cancer. For those that are 13 to 26 that never got the vaccine before they started becoming sexually active, they're still eligible to get the HPV vaccine. And in the US, the HPV vaccine was approved through the age of 45. So after the age of 26 up to the age of 45, it is still a possibility to get. It's a conversation to have with your provider. And then secondary prevention is cervical cancer screening. So in order to detect and treat precancerous lesions, so precancerous cells, precancerous abnormalities in the cervix that can then become a cancer if it's not treated. So that's the pap smear portion. So HPV vaccine, primary prevention, plus the secondary prevention with the pap smear. You still need HPV testing even if you had an HPV vaccine. A negative HPV test predicts lower cervical cancer risk over 3 years than a negative pap smear alone, which is why if you had a HPV test that's negative, the recommendation is to repeat it in 5 years, as opposed to the pap smear, which is 3 years. Next slide. Okay, so concerns over the vaccine. There is a lot of debate about whether you should do it. Is it going to be harmful? Can you next, please? So this was not fast tracked. Actually, the FDA approved this in 2006. However, it's been worked on since the 80s. It's been really, really well studied. There are multiple large scale trials done worldwide with like tens of thousands of people. Over 100 countries have an approval for the HPV vaccine. It does not contain a live virus. And there was a lot of reports about whether it could cause irreversible neurologic issues, permanent disability. The vaccine is safe. We have a lot of data, like I said, tens of thousands of people on study, as in addition to the people that just have received it off of study. And there are the things that have been reported in the VAERS system, which is the vaccine reporting system, shows that about 90% of the things reported have been pretty minor. So some people will get a reaction to the vaccine itself. Some people just don't like needles. So that it's been more along those lines. And even their relationships haven't really been found between the vaccine and any of the serious things that have been reported. Next slide. So what happens after an abnormal pap smear? Okay, you go, you get your screening, either pap smear, HPV test, both the way it's supposed to, and there's something abnormal. Either the pap smear comes back abnormal, HPV comes back abnormal. So the next kind of step is to have a colposcopy. A colposcopy is a way of looking at the cervix through a magnifying device. So this is kind of a good picture of what that looks like. And it just lets us see the cervix a lot closer to see if there's an area of interest where we would like to do a biopsy. So let's say the biopsy is performed. Next slide. Let's say the biopsy is performed and we find some kind of precancerous lesions or precancerous cells in the cervix. Well, this is a place where we can do something to prevent cervical cancer. In particular, and I like to use the medical terminology, even though it's a lot, but I think people should be familiar with it. Cervical intraepithelial neoplasia. It is a mouthful, but is really just saying abnormal cells in the cervix. They're given a grading system, and CIN 2 and 3 are kind of these high grade abnormalities. In particular, CIN 3 is a precancerous lesion that has to be treated. And if it's not treated, then it will likely progress into a cervical cancer. Similarly, adenocarcinoma in situ, which sounds very, very scary. It is still not a cancer, but is a pre-cancerous cell type, requires treatment as well. And typically that treatment is with an excisional procedure. Excisional procedures are one of two, either a LEAP procedure, which is shown at the top right, where we take a loop, an electrosurgical loop that's heated, and we basically do a larger biopsy of the cervix, or a cold knife cone, which this is done in the operating room. The LEAP can actually be done in the office, but a cold knife cone uses a scalpel to take a cone-shaped area or bigger biopsy from the cervix. So both of these can provide diagnosis, which means we either confirm that there are abnormal cells in the cervix, but we also make sure that there's no cancer seen once we take more tissue. And it can also be treatment, meaning that many times when we do either a LEAP or a cone procedure, if we remove that population of abnormal cells, lots of times that can be what we call therapeutic. Many women will go back to normalizing their pap smears, and it just might require kind of more intensive follow-up. Next slide. So I know that was a lot. I feel like that was longer than 10 minutes, so sorry, but just, some highlights. Cervical cancer is highly preventable through cervical cancer screening, including pap smear and HPV testing, as well as administration of the HPV vaccine. A high-risk HPV infection does not mean you will develop cervical cancer, but it really means that we need to follow you closer. Screening recommendations should be reviewed with your provider. So even though it's a recommendation, you are an individual and every person is different. And so having conversations with your provider is really important, and having someone that you trust is like crucial, because I think that's what gets people to kind of go back and follow up. Rates of cervical cancer among older women are increasing. And so I think that recommendation for stopping pap smears at 65 needs to be, it needs to be interpreted for every individual. And abnormal paps and or HPV results need to be followed up with colposcopy, and then if needed, an excisional procedure. Next slide. Thank you.
Thank you so much, Dr. Evelyn. We appreciate you. That was amazing. That was amazing, amazing. And so we have Gabby, Dr. Gabby. I forgot you got a PhD behind your name. Honey. We gonna say that. But just real quickly, we do see the Q&A. So you guys do have some questions down there. And we are gonna get to those, because we do have a Q&A section a little bit later. So we are going to get to that. So make sure that any questions that you have, drop those in the chat. And Dr. Gabby, the floor is yours.
Thank you. Thank you guys for having me join today. I'll kind of speed through this presentation just because there are a lot of duplication from our previous presenter. But my name is Dr. Gabby Darville-Sanders. I serve as the Strategic Director for the National HPV Vaccination Roundtable. Next slide. And I am so excited to be here. Cervivor is one of our many organizations that volunteer their time to preventing cervical cancer and advancing HPV vaccination in the United States. And so we could not do our work without all of these wonderful organizations that just contribute towards that effort for the nation. Next slide. So I'll talk briefly about HPV just because a lot of this has already been said. We know that it's a sexually transmitted disease. It's very common. So most of us probably have been exposed to HPV, especially as we've gotten older in our age. There's high risk, there's low risk types. Typically, next slide, the low risk types will clear on their own, but some of the low risk can contribute to genital warts. The ones that we are really more pressing for is those high risk types. And therefore, as the previous presenter said, a lot of times we'll see cervical cancer or precancerous cells develop starting at age 35. And this is important because we would have contracted or been infected with HPV. Typically, we see between 15 and 24, but it can actually be earlier than that. And oftentimes the virus just stays dormant. There's an infection, that's something that triggers it, and then we start to see the development of cervical precancers and therefore cervical cancer. So it can take decades before someone starts to physically manifest the symptoms associated with cervical cancer. Next slide. And so the tip of the iceberg, we tend to see a high incidence of cervical cancer rates in the US. It's about 12,000 that we tend to see. But that still doesn't show the big picture in that oftentimes we have a larger incidence or prevalence of cervical precancers. And I'm here not just talking as a strategic director for the National HPV Vaccination Roundtable, but I'm also talking as a sister of my sister, my biological sister, who was diagnosed with precancerous cells. And the previous presenter talked about, having to have a LEP procedure and some of the pain and dysfunction and just the things they have to go through of even addressing the precancers. And so this is why screening is important, but this is even more why HPV vaccination is important. HPV affects both men and women. So women can also get some of the other cancers. So head and neck cancers can develop in women. We also see anal cancer. Remember, HPV just needs a mucous membrane. Sometimes it doesn't really matter the site of clinical manifestation. So we've seen cases of women having head and neck. We have seen cases of women having cervical. We've seen cases of women having anal. We've also seen cases of women having vulvar and vaginal. Men can also have head and neck, as well as penile cancers and anal cancers. So it does affect both men and women, and this is why vaccination is important for both boys and girls. Next slide. And so we always say we have about 36,000 new cases that we anticipate every year. If you look at the end of the pyramid, we always say from an injury prevention or prevention perspective, the tip is what we always hear, but it doesn't mean that that's the only thing that's happening, right? And so we have 36,000 cancers that are happening. Imagine the number of high-grade cervical cancer, precancers, right? Imagine the number of genital warts. Imagine the number of low-grade, and then the abnormal PAPs that we see. And so 36,000 is just representative of the larger issue as it pertains to cervical cancer prevention. Next slide. So cervical cancer disparities, really quickly. Black women are more prone to die, have a higher risk for. This risk increases with age in the United States. Next slide. We also see that among Black women, rurality, so if you live in a rural area, if you're a lower SES, if you have access issues, insurance issues, are socially disadvantaged, therefore the risk is even greater. Next slide. And then when we add being a member of a sexual and gender minority group, being a member of the LGBT population, right, you have issues even exacerbated. And so LGBT plus Black women are not just cervical cancer, but even breast cancer, because there's a lot of lack of knowledge among providers, a lot of misconceptions, high level of stigma, and then we tend to see high levels of homelessness, right? So depending on who you are and your identification and those different factors that contribute to you, then the cervical cancer disparities can even be even greater. Next slide. So HPV vaccination works. About 90% of cancers can be prevented through HPV vaccination. We see that 9 out of 10 cancers are caused by HPV. So this is why vaccination combined with screening is even more important. Next slide. And so we have the Gardasil 9, which it's beautiful that it protects against 9 strains. When I got vaccinated with Gardasil 4, so 4 strains, and then Cervix is the previous iteration. But in the US, Gardasil 9, or the 9-valent, is what you will hear as the most recent recommendations for vaccination, and they protect against multiple strains of HPV that can contribute to cancer. Next slide. So just addressing misinformation. It does prevent cancer. HPV vaccination is cancer prevention. It works best between 9 and 12. So we're actually pushing an earlier age of 9 to get these kids vaccinated early before sexual peaks, right? But also just to protect them. There's been suggestions of a great immune response to the vaccine when you start early at age 9. It's both boys and girls. And fun fact, boys sometimes are the highest carriers of, but are not symptomatic. And therefore, when engaging in sexual activity can then transmit it to our young women. And therefore, we see a higher burden of cervical cancer rates later on. It is safe. It does not contain harmful ingredients. It does not cause fertility or reproductive issues. It lasts for a long time. There's evidence to show there's no waning over time. And that even if there's issues of access barriers or insurance, or you can't afford it, we have programs set up to support all eligible persons getting vaccinated for HPV. Next slide. So the problem is NIS Teen, which is the CDC's tracking for vaccination, has shown us that we're actually, for the first time since the introduction of the vaccine, we're not seeing any gains. So our adolescents specifically are not getting vaccinated as they should to protect them later on in life against cervical cancer. Next slide. And this is very important because we can tell also between Black and brown communities that our kids, there's vaccination trends that differ. So we're more likely to start the series, but we're not always the ones to complete it. So this is why completion and not just initiation is important. So before the age of 15, we recommend 2 doses, 6 to 12 months apart. If you start after 15, then it's 3 doses. We encourage starting early at age 9, especially with flu vaccine and COVID vaccine, and then the Tdap and meninge that all kind of happen around 11 to 12. You start at age 9, you get them vaccinated at 9, so that's one less shot that they have to get at the 11 to 12 well child visit. If you've gotten vaccinated, you have not gotten vaccinated before 15, the ACS does recommend up to 26. And that's just because we know that by age 18, you've been exposed to some form of HPV, so the effects may not be as great as early ages, but the CDC does recommend up to age 45. And as the previous presenter said, this is really shared clinical decision-making with your provider to discuss your risks, discuss the benefits, and then make a decision on should you go ahead and get vaccinated. Next slide. We know HPV works. So there's data coming out now from Sweden, England, and Scotland. This study showed us over a 10-year tracking time period, women who were vaccinated before the age of 17 had an 88% chance of protecting themselves against cervical cancer. And they tracked them for a long period of time. Next slide. We saw similar results in a study in England. It showed us that if kids and young women were vaccinated by between 12 and 13, they had a 87 and 97% protection rate against not just cervical cancer, but precancers as well. And in our last study, in the next slide, that just came out this year in Scotland, they actually tracked women who got vaccinated at the age of 12 to 13 in 2008, and we're now 2024. There were no cases of cervical cancer detected at all in these women who were vaccinated early, starting at age 12. So the science is there, the data is there, and we know that vaccination works. Next slide. So the World Health Organization has also made a dedicated effort to the elimination. Yes, we can eliminate cervical cancer in our lifetime. Our wonderful visionary leader of this group has been so proactive in that space. You know, the World Health Organization says 90, 70, 90. So let's get 90% of kids vaccinated, 70% of women screened, and 90% in treatment. The American Cancer Society is leading national efforts for the United States. We're proposing 90, 90, 90. We need to get 90% of kids at least vaccinated, 90% screened, and 90 treatment focused. And so we can work towards the elimination of all HPV-related cancers, starting with cervical cancer in the United States in our decade. Next slide. So call to action, get your vaccines on time, get screened on time, advocate for yourself, for your family, for your children when you're engaging in conversations with providers. Engage in dialogue. We as a community sometimes don't have these conversations, and information and awareness is key. So take what you've learned today, have conversations and dialogue with your family, those in your community groups, so that we can get more people protected against cervical cancer early on. And then if you're able to start vaccinating your kids starting at age 9, so that by 11 and 13, they have full protection. And next slide. If any questions, please reach out to us. We're always willing to help in any way that we can. And I appreciate the opportunity again.
Dr. Gabby, thank you. Thank you so much for your participation. And we have Tira, who is going to tell her story. She is, of course, a cervical cancer survivor, but also a survivor community member and ambassador. So Tira, we're going to hand it over to you.
Thank you so very much. And thank you guys for lending your Saturday and your time. My name is Tia Wade, and I reside here in the lovely state of Ohio. And I am a 2B cervical cancer survivor. I was diagnosed with that in the middle of the pandemic. So part of those 600,000 people, I was one of those persons diagnosed. My life before cancer, I am a wife, I am a mom to 3 daughters, and I was in a career that I loved, creating art, and also a jewelry designer. So I was living a life that I considered to be full, but not purpose-filled. And because of this diagnosis, it's kind of propelled me into turning cancer into one of the best worst things that could have happened to me. I now, like Kimberly has echoed, now dedicated my time to education, awareness, and prevention. So one of the biggest things when I had the pleasure of meeting Tamika, was just saying that if you know me, we're not going to be silent anymore. Not on my watch. It's kind of like the promise that I have given, not on my watch. If you know me, we're going to be educated, we're going to be informed, we're going to be empowered. So I actually was diagnosed with HPV at the age of 24 after my second daughter, and kind of fell between the cracks of some of those health disparities that we talk about. I was a single mom at the time. Just they became my priority. So my health screenings, my doctor visits, were kind of put into the back burner, and I did not prioritize my health and the conversations with my OBGYN was never, this is something we really need to kind of watch closely. It was almost a put at shame to say, why do you have this so young? And because of those words, I again didn't have the type of support to kind of prioritize what I ultimately needed to. And so now, on the other side of this, I take the time to educate young women and ask them, hey, not to be judgmental, but kind of more of a self-love act. If you love yourself like you say you do, you're going to take care of yourself. And so that's kind of what I've dedicated, educating them about, when's the last time you had a screening? And then also in my community, kind of breaking that stigma. As African Americans, we have this unfortunate saying, what happens in our home stays in our home. And not being educated is something that I have kind of dedicated to letting people know about. The HPV shot is cancer prevention, and kind of erasing and breaking down these barriers and stigma behind that vaccination. So I'm proud to say that all 3 of my daughters have been vaccinated fully with the HPV vaccine, and my desire and continued dedication to making my community aware and nationwide and globally, along with Survivor, on impacting so nobody else has to suffer through this disease. Treatment was a breeze, but I'll be transparent. Survivorship has definitely had its challenges. And so if I can prevent just one person, I hope that it's more. But again, if just one person that says, I'm going to go ahead and schedule my children to be vaccinated with the HPV cancer prevention, is just how you need to phrase it. Or for a woman to say, you know what, I've been having these symptoms. Could you direct me to where I need to go? Or I've scheduled to have my pap smear. That makes it worth it for me.
Thank you so much, Tira. I appreciate you. Now we're gonna have Miss Gwen. And you can advance the slide. Thank you. So Miss Gwen is one of our community members as well. So Miss Gwen, the floor is yours.
Hello, my name is Gwen Jackson. I am from Houston, Texas. My life before cervical cancer, I was a case manager, a damn good one, I must say. I housed homeless individuals, and I was already running and operating. I was a CEO and a founder of a nonprofit cancer organization in memory of my father, not knowing that I would be a patient myself. Um, I found out I was diagnosed also during COVID. I found out November the 17th, 2020. You never forget the day that you was diagnosed. It started with I had heavy bleeding. I ended up going to the ER because I ended up was leaking clear fluids from my vagina. So that was the reason why I went to the ER, because I was like, I know I'm not pregnant. I know my water bag didn't just burst. So I went to the ER, and from there, that's how I found out that I was diagnosed with cervical cancer stage 3B. And from there, my whole life went spinning out of control. I have had 3 strokes. I have had 2 heart attacks. I have had my cancer have spread it to my bones. I'm still thriving. My cancer has spread it to my bones. It hit my jaw. Thank God it didn't hit the brain, it hit my jaw instead. And when it hit my jaw, I lost teeth in the back and lost some hearing in my ear. So if I can help anyone to not experience what I have been through, that is my plan. I did go for screening. Every year I went for my pap smears because my insurance, Blue Cross Blue Shield, will pay you $75 if you went for your screening. So I always went for my screenings every year. My doctor said I had fibroids because my tumor was under my fibroid. So, and then test me for HPV. I was at small, very small percent that didn't test positive for HPV. So they missed it. They didn't see it because I had all the same symptoms of fibroid tumor, and cervical cancer have some of the same symptoms. So they was missing it. Now my life, I am on clinical trials. My life has changed so much. For example, if y'all look at my background screen, mine is different from everyone else because I'm going to be as real as I can be. Because of the strokes, I am not the same person I used to be. So now things are difficult for me to retain information and to do the things that I used to be able to do that was so easy for me, that now it is so difficult for me. So my life have changed so very much, but I still thrive every day to try to be a better me and to learn who I am daily. I'm learning the new Gwen daily because I realize I'm not the old Gwen who I used to be. So that's my story.
Miss Gwen, thank you so much. Thank you so
You're
much
so
for
welcome.
being vulnerable. Thank you so much for sharing your story and always being available. I appreciate that. I really do. I really.
No problem.
Tira, same thing to you. Thank you. Thank you for your vulnerability. Sorry, can't even get my words together. That was so touching. We have ran out of time. And I know that we have a list of questions that we wanted to get to. We are unable to get to those Q&A questions, and I apologize that go ahead.
Kimberly, I'm sorry, but
Uh-huh.
I believe we got them all answered in the chat.
Oh, we do. Okay, great, great, great. I saw you were giving some instructions there, Tamika, so I do apologize. So
No, no.
if you guys have it, and I know that we did receive some questions, we will get those answered. And when we're able to get this recording available to those that registered, we'll get those questions answered, and maybe we can kind of give those to you guys at one time. But so you can move to the next slide. And we just want to say thank you. Thank you for joining us. Thank you for spending a part of your Saturday with us. We appreciate you so much. Hopefully you gained something. I know that I gained some things as well from this launch of Black Cervix Chat. We definitely want to make sure that we change those statistics. That's one of the things that we want to do. We want Black people to go and have their screenings, get vaccinated. Don't be afraid. That's the only way we can eliminate and eradicate cervical cancer. And that's all of us working together to eliminate cervical cancer. Tamika, did you have anything else before we log out?
I do. Yes, I just want to say thank you to all our wonderful panelists, our patients, our experts. Y'all got me in tears over here.
Yes.
Ah, so beautiful. I always take away something, and I've got 3 nuggets now that I have in my toolbox when I speak to just family and friends, and also when I speak in front of groups. So I hope you all receive the same thing. I also want to encourage anyone who has an idea and they want to do something. Black Cervix Chat was an idea that Kimberly sent me, and I said, sure. And I have literally let her run the show with this with little to no input at all. And I just want to say I'm proud of you, Kimberly, and thank you for making your survivorship count.
Thank you. Thank you. You guys, that's it. That's what we have. Please connect with us. We are on all socials, including Pinterest. We're there. So definitely connect with us. And in our next, we're gonna be having a Black Cervix Chat near you. So please look for any of that as well. And we'll see you next time. Thank you so much.
Bye,
Bye,
everyone.
Thank you so much.
And thank you to our international listeners. Thank you for coming and joining us. We see you.
yes,
Thank
yes.
you.
Thank you. Thank you.
That was really, really, really wonderful. Thank you.